Okay, this is part 2 of your lecture on the respiratory system, bronchodilators, mucolytics, and expectorants. You may hear a little scratchiness and sniffling in my presentation because right now I am currently dealing with an upper respiratory issue. So some of these medications are right on board with me right now. So it's very appropriate for this lecture. During this session, you should be able to describe what chronic obstructive pulmonary disease is, COPD, and how some of the other respiratory disorders relate to it. You should also be able to describe how the bronchodilators work, their mechanism of action, and the primary effects of the 3 different types of bronchodilators we're going to talk about. In addition, you should be able to explain the therapeutic actions of corticosteroids and leukotriene inhibitors and their relationship to the treatment of asthma. And last of all, you should be able to explain the use of mucolytics and expectorants in treating respiratory disorders. Now, first we're going to just a little bit of brief background on the disorders that we're going to be primarily focusing on, and that is disorders primarily under the umbrella of COPD. COPD, chronic obstructive pulmonary disease. And as I said, it's kind of a large umbrella that incorporates a number of different disorders within it. If a disorder is a long-term disorder, it's chronic, and it causes airflow resistance to the movement of air through the airways, it is considered a chronic obstructive pulmonary disorder. 2 of the most common ones that you're probably familiar with are emphysema, and that's the one whereby people can get the air in, but the alveoli are so damaged that they have trouble getting air back out. And then asthma, that disorder that you're most familiar with that causes the symptom of wheezing that you hear when people get it. A little bit of time focusing specifically on asthma because when you understand a little bit about the process of asthma, you may understand better than how the medications that we use for it work. Asthma itself is a respiratory condition, and as we said, it's characterized by bronchoconstriction, shortness of breath, and in many cases we also hear wheezing along with it, and that wheezing is one of the big key factors that you've got severe bronchoconstriction going on. It's considered to be an anti-inflammatory disease. I'm sorry, an inflammatory disease. Not an anti-inflammatory disease. It's a disease of inflammation in the lungs. Individuals with asthma have what's called a hyper-responsiveness to some environmental factors. And these can include things such as allergens, air pollutants, cold air, certain drugs, infections, and even in some cases exercise may be the trigger that causes an asthma attack. Now, why do you get an asthma attack? Well, what happens is one of these factors stimulates the release of chemical mediators. That's chemicals that are present in the mast cells. And if you recall, we talked a little bit about mast cells in the last lecture. And what happens is when the mast cells release these substances, they cause bronchoconstriction and inflammation. As a result, they cause an asthma attack. Now, when someone has an allergic type of asthma, if you recall from what we talked about with antihistamines, it's an antigen-antibody reaction. So what happens is they are exposed to a foreign protein, the antigen, and then after the exposure, they create an antibody and then after that antibody is created, the next time they have an exposure, they end up having a reaction releasing the chemical mediators from the mast cells and triggering that inflammatory process. So when you take that combination of the airways getting smaller, bronchoconstriction, and swelling in the airways, and then throw in that many times what happens is we get increased mucus production, and increased mucus production further narrows the airways. All these things together make it difficult to breathe, and you see that shortness of breath and may hear that whistling, wheezing sound of air trying to get through those very narrow airways. To relieve asthma attacks, we use a variety of different medications. And we are going to, one of them will be bronchodilators. We also use anti-inflammatories. And then we may go back and use some of the antihistamines that we talked about too. So we're going to, as we progress through here, discuss how some of those medications then interplay with interrupting this asthmatic process. Now, I did mention chemical mediators, and I just kind of wanted to talk a little bit to make sure we have a good understanding of what chemical mediators really are. So during the inflammatory reaction, chemical mediators are formed and released from the injured tissue, specifically from the mast cells. And in this case, we're talking about in the respiratory tract. They are responsible for most of the symptoms and the complications that we have with asthma. So whenever you get injury to a body tissue, when those mast cells break, histamine is released. In the respiratory tract, histamine causes bronchoconstriction, increased vascular permeability, which means that the vessels become more permeable. That contributes to the mucosal edema, the swelling in the tissues, because you have more fluid in the tissues, and you get an increase in production of mucus. There's a second chemical mediator that also comes into play, and it's the eosinophilic chemotactic factor. And what happens, it attracts, when the reaction occurs, it attracts eosinophils to the site of the area, and eosinophils are part of that inflammatory reaction, as you might remember from anatomy and physiology. And that then, the increased number of eosinophils further increases the inflammatory reaction and makes it even worse. So these are the two factors that we see coming in when we're talking about these chemical mediators. A couple of other chemical mediators that we may also see coming about are prostaglandins and leukotrienes. Now, prostaglandins and leukotrienes are both derived from arachidonic acid, and they are both formed and released when you have inflammation occur. Both of these will also cause bronchoconstriction, edema, and mucus production. Prostaglandins are also involved in the general inflammatory process throughout the body, and they generate muscle cramping and pain also. Now, we don't typically see pain when we're talking about asthma, but when we're talking about, back when we were talking about our analgesics, and we talked about some of them have a prostaglandin effect, you may remember that the prostaglandins triggered pain in an anti-inflammatory process. The leukotrienes are potent bronchoconstrictors with a really long duration of action, and they're considered to be probably one of the most important chemical mediators when we're talking about someone who has a long-term chronic asthmatic problem. we want to treat asthma, we're going to look at a couple different kinds of medications. And the first thing we're going to look at is bronchodilators. And there are several different classes of medications that provide bronchodilation. And particularly, we're going to look at 3 of the classes that affect bronchodilation. And the first is beta-adrenergics. This should be very familiar to you. We've talked about this before. You're going to find this now as we progress through the course. Classes of medications, or you're now going to see them overlap for different body systems. So if you've got it the first time, you're going to have it this time. If you didn't get it the first time, this is another opportunity for you to pick up the information on that medication. So the beta-adrenergics, if you remember, can you remember what the parent class or the parent drug was for this class? Okay, if you recall, the beta-adrenergics, their parent drug for this was epinephrine. And epinephrine causes sympathetic nervous system stimulation. So if you remember, the smooth muscle of the bronchi is relaxed when you stimulate the sympathetic nervous system. That fight or flight response needs you to open up your airways to get more oxygen in. So when we stimulate the sympathetic nervous system, we will relax the airways and open them up. So when used as bronchodilators, beta-adrenergic drugs are the drug of choice in the control of asthma and COPD because they cause those smooth muscles of the airways to relax. Some examples that we have that you may be familiar with: Proventil and ProAir. ProAir was one of the ones on your drug summaries. They are both beta-adrenergic bronchodilators. Now, since these beta-adrenergics are usually administered by inhalation directly into the lungs, you really do see very few systemic adverse effects of them, like when we talked about our oral preparations back when we were talking about cardiac medications. The common things that we do see, though, might be nervousness, some tremors, and an increased heart rate. And so those are the most common things that we see along those lines. So again, if you remember back to what we talked about with beta-adrenergics, it makes sense that they would, because it's a sympathetic nervous system stimulator, you would see the heart rate going up, and you may see some nervousness and some skeletal muscle tremors. Okay, so the second then of our 3 types of bronchodilators are the anticholinergics. Now, by blocking the action of acetylcholine in the parasympathetic nervous system, as you might recall from before, the anticholinergics will produce bronchodilation. Because if you recall, the parasympathetic nervous system will cause bronchoconstriction. So if we block acetylcholine, we will allow the bronchioles to relax, and then we will open up the airways. In addition, acetylcholine also has the effect of decreasing some of the mucus in the airways too. So it's a secondary effect to bronchodilation that may also be helpful in treating an asthmatic reaction or a COPD condition. Now, anticholinergics, though, are not as potent bronchodilator as the beta-adrenergics. And so they're usually used when, for some reason, someone can't take a beta-adrenergic or they need it on top of a beta-adrenergic because of the severity of their reactions. Now in COPD, especially if we're talking about like something like chronic bronchitis, there appears to be an increase in cholinergic activity in the body. So sometimes the anticholinergic actions are really useful in treatment of chronic bronchitis and emphysema because of those very effects. It seems to have, we see more cholinergic response in those two disorders versus the asthmatic disorder. The most common side effect we see with the anticholinergics are xerostomia. And if you recall from before, that's that dry mouth, along with just dry mucous membrane. So people complain of dry eyes, dry nose, dry mouth, those kind of things. So we do really need someone who is on an anticholinergic to make sure they are taking plenty of fluids, and that is non-caffeinated fluids such as water and juices and things like that. Common examples of anticholinergic bronchodilators would be Spiriva is one, and Atrovent would be another one that are commonly used today. Okay, the third class of bronchodilators we're going to talk about are the methylxanthines, and particularly one called Theophylline, because it's really the only methylxanthine that has bronchodilating actions. Theophylline is from a methylxanthine or a xanthine compound. Xanthine compounds are found in cocoa, tea, and coffee, very closely related to the compound of caffeine. And what happens is, specifically, this theophylline will go and inhibit an intracellular enzyme called phosphodiesterase. And you may recall, as I started to talk about this, that phosphodiesterase was involved in that chain of creating or breaking down, inactivating cyclic AMP. What happens is theophylline inhibits this enzyme phosphodiesterase. As a result, the levels of cyclic AMP can increase in the smooth muscle of the bronchioles, and therefore the smooth muscles can relax. Now, in addition to bronchodilation, the theophylline has also been shown to increase respiratory muscle contractility. So the respiratory muscles and the diaphragm are skeletal muscles. Since these compounds have an effect on skeletal muscles, it can increase the contractility of them. It also helps with clearance of mucus. So when you put all that together, it makes sense as to how these medications may be helpful in treating someone who has chronic asthma. Now, the most frequent side effects related to the oral administration of theophylline are increased heart rate, nervousness, insomnia, and tremors. And all that makes sense when you talk about the fact, if you think about xanthine being related to caffeine, what happens when you have caffeine? Increased heart rate, nervousness, insomnia, muscle tremors. So it all makes sense. This is not as commonly used as it used to be, but because it is an oral form and can be taken on a daily basis, it did have and still has some very good warrants in dealing with children who have chronic asthma, so that they don't have to as much carry inhalers around, and you're not relying on acute management of it. It's more of a long-term management. Now, in addition to the bronchodilators, then we also talked about we treat asthma and COPD conditions with anti-inflammatories. Now, the anti-inflammatories that we're going to talk about include steroids and leukotriene inhibitors. The steroids and leukotrienes are referred to as a controller drug, and that's because they, rather than are directly dilating the bronchioles, they're dealing more with reducing and controlling that inflammatory response. The corticosteroids are really considered to be one of the most potent anti-inflammatory and anti-allergic drugs available. They interfere with all stages of the anti-inflammatory process, and they inhibit activity of the inflammatory cells, the release of inflammatory mediators from the mast cells, the production of antibodies, edema, and a number of anti-inflammatory reactions. So they really are a whole package deal when combating inflammatory conditions. Now, one of the main uses for these drugs is for treatment of asthma. And the major effect in the treatment of asthma is that they inhibit that inflammatory response that's occurring right in the airways. Usually, most commonly, we'll use them in an inhaler form so that it gets directly into the lungs. Now, steroids themselves, if systemically, you might see fluid retention and some muscle wasting, metabolic disturbances, increased susceptibility to infection. But the inhaled steroids, because they don't have as much of a systemic effect, primarily the side effects that we see from them are the increase in oral infections, usually fungal infections, because of the steroid collecting in the airway and not getting rinsed out. So it does become important as part of a teaching factor that they do, after using an inhaled corticosteroid, that they do rinse their mouth out, so that will decrease the effects of the changes that can occur within the normal flora of the mouth. In addition, the stuff tastes pretty rotten too, so rinsing your mouth out helps with that. The other thing they can cause is they can cause some hoarseness and some vocal cord disturbances as the compounds go down through the larynx. Common ones that we see used would be Advair, which is on your drug summaries, and Flovent is another very common inhaled corticosteroid that we use in the treatment of inflammatory conditions. The second type of anti-inflammatory that we're going to discuss is that of the leukotriene inhibitors. Now, really a major focus of asthma research has been to discover drugs that inhibit the actions of the leukotrienes. If you recall back from the beginning, leukotrienes are a chemical mediator that will cause bronchoconstriction, mucus production, and inflammation. So these medications that block leukotriene are considered to be leukotriene inhibitors, and they're really indicated for chronic control of asthma. They are not very effective as an acute treatment, but they work well to include someone who has a chronic asthmatic condition. An example of a leukotriene inhibitor from your drug summaries would be that of Singulair. This is how the product Singulair works, by inhibiting leukotrienes. Side effects that you can see from these primarily are nausea, diarrhea, rash, and headache. One of the more serious side effects that you can see involves the liver. And so you do periodically want to, someone who's taking this medication, watch their liver enzymes, or if they start complaining of fever, and dark urine, and jaundice, those are all signs of liver toxicity. and they need to report them to their physician promptly. We need to look at the last type then of symptoms and signs that we're going to treat in COPD conditions, and that would be that of the mucus production that comes along with the edematous process that's happening in the airways. Two types of medications that we use for treating this particular signs and symptoms are mucolytics and expectorants. Mucolytics, what they do is they actually liquefy the bronchial mucus. The bronchial mucus can become thickened as an inflammatory condition progresses, and also as you get more and more accumulation. They can become very thick. And when you get thickened mucus in the airways, it becomes a dark, warm, moist, perfect media for infection to set in. So we want to get that thickened mucus out so that the bacteria, fungus, viruses are not collecting in it and staying in it. So mucolytics are very good in that they liquefy the bronchial mucus. They make it thinner. An example of this would be our little guy over here that you might be familiar with, Mucinex. Mucinex is a very well-known mucolytic. Does a great job at liquefying bronchial mucus. Now, once the mucus is liquefied, some people may need help with getting it out. And so we often will combine a mucolytic with an expectorant. Now, if people have an accumulation of mucus, or they have a cough that's non-productive, and we want them to be able to cough stuff out, we may just give them an expectorant. Or we may again use the combination, thin the mucus, and then give them an expectorant to cough it out. So what expectorants do then is they encourage the coughing, encourage the removal of the mucus from the lungs and the airways. Common one for this is guaifenesin. If you look at many of your cough syrups, you may see that it has guaifenesin in it. And guaifenesin, the purpose is to help you expectorate, to help you remove that mucus from the lungs. So these two can be used individually or in combination to, one, liquefy the mucus, and two, then get it out of the lungs. So just kind of a nice little summary slide here, looking at preferred therapy for patients who have asthma and COPD conditions. Patients who experience less than 2 asthmatic episodes per week usually do not require a daily medication. So the beta-adrenergics, bronchodilators, really provide an immediate onset. So they very quickly will go in and take care of the condition in a matter of seconds to minutes. Things such as, and another example of this would be like albuterol. They can carry it with them, and they use it when they get the onset of symptoms. It's called a rescue inhaler. You may have heard that term. Patients who experience more than 2 asthmatic episodes per week, but less than 1 per day, so maybe 2 or 3 in a week, but not every day, are usually prescribed with a daily treatment of a low-dose inhaled anti-inflammatory steroid. So you may see a low dose of a steroid every day to keep that inflammation down. Alternately, you could see some cromolyn, and you may see the anti-leukotrienes used to control what we call a mild persistent asthmatic condition. Patients who have daily asthmatic episodes would be considered moderate persistent, and they require a daily treatment with a low to moderate dose of the corticosteroids and the beta-adrenergic bronchodilators. So their albuterol may be used on a daily basis, and then we may include some longer acting drugs in there also for chronic therapy. Severe persistent patients require high doses of inhaled corticosteroids and long-acting beta-adrenergic bronchodilators. They may also get oral or injectable steroids when symptoms intensify. So we may also need to bump up those and give them a systemic steroid if the symptoms get worse. Additional bronchodilators and leukotrienes can be added depending on their situation and how they respond to them. So it becomes one of these, a little of this, a little of that. Well, that's not working. Try a little more of this, a little less of that. Becomes the recipe that we use for someone who has a severe and persistent chronic obstructive condition. Okay. Couple things here just to check in with. I'm going to give you a couple scenarios, little case studies here. First, I have Mrs. Peabody, and she is prescribed Advair Discus for the treatment of asthma. Now, the directions on the insert tell her, rinse mouth with water after inhalation. Why is this? You'll find a drop box called the Mrs. Peabody drop box. Think about the question and then submit your answer into the Mrs. Peabody drop box. And our second little mini case study here is that of Jonathan. Now, Jonathan is wheezing and he is short of breath. And you have the option of giving him two medications. One is Spiriva and the other one is ProAir. I want you to pick one of those. Tell me which one you chose and why. And then put your answer in the Jonathan drop box. It's up on D2L. And last but not least then are your drug summaries for our next unit. And our next unit will be the gastrointestinal system. And so we have 5 medications related to the gastrointestinal system. And you'll want to research each of these medications and then submit them into the drug summary form up on D2L. And those would be Nexium, Prevacid, Acifex, Asacol, and Protonix. Right. Good luck after you finish your materials here. Good luck on the quiz, and I'll talk to you next week.